hold it and pop it in the chat?
Nope, I got it.
Comes out? Okay, you got it. All right.
Yep.
Groovy.
Where did they go? Oh, there they are. Hi, Bunya. Hi, Sheila. Hi, Anne. Welcome, welcome, welcome. Thank you for joining us. Good to see you guys again.
Everyone.
So when I do
Yeah.
switch it over, Celeste, just let me know if it's not readable.
Right.
Hello, everybody. Hi, Tracy. Welcome. Hello, hello. Hello, iPhone 4 user. Hello.
Very specific.
Welcome, everybody. I know you guys are on mute. You're kind of experts at this point, understand the routine. If you are the iPhone 4 user, if you could put your name in the chat or rename yourself in the participant list, just so we know who that is, that would be helpful. Especially when questions are asked and as we're interacting through the session, that'd be very great. Guadalupe, hey, Dr. Raymond. Dr. Raymond, Guadalupe just finished her ED, so she is now officially Dr. Guadalupe Raymond. So welcome, thank you.
Nice.
Glad to see you guys. I'm just going to change your name for our knowledge here, Lupe. And put Dr. Lupe. Okay. All right, so I see Anne, I see Bunya, I see Guadalupe, Elisa, Sheila, and Tracy. Welcome, guys. I'm going to go ahead and put the pre-questionnaire survey link in the chat box for you all to take a second. And just as a friendly reminder, just like the previous 3 sessions, you guys will be on mute throughout this, just so there's no sort of noise interference or whatnot. Any questions you do have throughout the session, feel free to throw in the chat box, and Celeste or myself will respond or reply. Even Mark might chime in here and there. And then obviously we'll have our knowledge checks and quizzes throughout. So if you could make sure to participate, that lets us know that we're keeping you kind of engaged. And obviously, if you have any questions or anything, regardless, throw in the chat box and we'll make sure to address it during the session. We'll have some time at the end as well. So without further ado, I'm going to turn it over to my colleagues and they're going to take it over.
Good. You're up, Celeste.
Hi, I'm Celeste Harvey, and I am an associate professor at the Chicago School in Dallas, and I've worked with the National Association for the Dually Diagnosed for about 5 years on different projects. This is one we've worked on for, gosh, Mark, I think 4 years. Is that right? Yeah, 4 years. Developing training on how to detect early signs of crisis and how to intervene at each level as potentially a person that we care for or know of is dealing with some situations that may lead to a behavioral and or mental health crisis. So I will turn it over to Mark now. Hello.
All right. Mark T. Harvey. I just want to put that T in there so I don't get confused with other Mark Harveys. There are several out there. One of them is a very prominent cardiac surgeon who does some kind of lecture service or series. And at one point in time, I actually said, you know what, I'd really love to go to Oslo, and said I would be happy to come and do a presentation. And it turned out that was the wrong Mark Harvey. So my background is in special education. I've been working with individuals with intellectual developmental disabilities for about 35 years. I did start working with NADD 4 years ago, and I really love this opportunity to talk about individuals who have IDD and co-occurring mental health issues, especially when it comes to behavioral mental health crises. There are a lot of times where we need folks who have backgrounds in both ends, that is, in the mental health end, but also in the behavioral end of things, and want to figure out how do we work together so that we can do this. This is our last in the series. This is on post-crisis, so this is after the crisis has occurred. How can we learn from some of the things that have occurred? But before we get there, we want to make sure we acknowledge the FDDC, the Florida Developmental Disabilities Council, and their support with this training series and all the research that we've done with them. With that, if you like what is being talked about and being said, being projected on your screen, please let FDDC know that thank you for the supporting our projects. If you don't like it, then it's on me, and put it back on me and say, oh, he just didn't have the right feel for this. His vibe was off for the day. So with that said, let's get on with post-crisis. Hopefully everybody smashed that pre-test button. They got it all done. If you haven't, go to it. There is the QR code there, and there's also in the link in the chat. So again, please note the definitions, eligibility requirements vary across age ranges, states, services. We are going to be talking about the state of Florida, but we understand that there are some folks here who have either in the past worked in Florida and may not actually physically be housed in Florida at present. But that's okay, as long as we acknowledge that you know what definitions for intellectual developmental disabilities, definitions for the requirements to get into waiver systems, all those will change by states, by counties, and by service systems that you're in. So with that, please refer to your resource lists, or you can connect with disability support contacts for more information. So FTDC, they're good. Thank you for all your help, all your supports. Definitions will change. And the other one that maybe it's in here later, I just want to make sure that when we're talking about crisis, that we get to the point if it triggers an emotional response in yourself and you need to take a break, please do that. Make sure you get that opportunity to take a break, whether it's to call a friend, whether it's just to meditate, whether it's to use the box breathing that Celeste had brought up in the previous one, or you just need to hug a dog, a squirrel, whatever it may be. Do so, de-escalate, because we don't want to trigger any kind of trauma in individuals who are going through this training series with us. We like you guys. We appreciate you. Thank you. So our learning objectives for today, we're going to start off with how to manage a critical incident to minimize the impact of stress. We're going to talk about how to use a debriefing process and the tools that are associated with it to describe what happened as the crisis developed. What happened within it, and how can we get that information? How do we get to a point where we can either minimize the likelihood it's going to occur again, or if it does occur again, we can help to mitigate the situation. So we're going to discuss what happened during that crisis, describe what worked, and identify any barriers or things that didn't work during those previous crises. From that, we're going to develop the plans for future incidents so that we can become better clinicians, we can become better support agents. And then the way we're going to do that is to amend the personal crisis plan that you have in place, and making sure that we get it updated and we learn along the way as we go. So we're hoping that you can craft a trauma-informed response plan to debrief and proactively manage any future incidents that may occur. So here's our roadmap. In this training, we're going to talk about the critical incident stress management, or the CISM. As part of that, we can talk about debriefing, what is the process of it, and some of the tools that have been used for debriefing. A lot of this comes out of the literature that's relating to first responders. They started off with this critical incident stress management, and they have some really great tools to kind of de-stress and prepare themselves for incidents before they even happen, so that they can better process it and it doesn't lead to trauma. That's kind of where we want to go with it. We want to ensure continuity of mental health care and develop cross-professional collaboration and coordination. Take a quick pause. Okay. So one of the things we're going to do is amend the individual's personal crisis plan. With them, we want to make sure that this is a person-centered planning procedure, that all people that are that you're working with, that you're supporting, actually are able to participate in this and they're able to give their information. And that's really what we want to get to the point is where we can teach them to start to identify what their triggers are, start to identify when they start to feel the escalation coming on before they get into that escalation itself, in some ways that we can get them to de-escalate. So. Two dogs decided to make noise behind me, so we're going to take care of that. Critical incident stress management, CISM. So that is kind of the question is, well, how are you? And how are you really? I love the great philosopher Elmo that put that email out there that said, how's everybody doing? And he got responses that weren't really expected. But I think that's really that question, right? That is, once the incident has occurred, you get to the point where it's maybe a little bit over, or at least it's de-escalating. And the question is, how are you? And these are the questions too, where this is the question that we should also be asking the person that we're supporting. So part of that is this CISM model. And this was, again, designed for individuals who are first responders, that is police, but ambulance crews that go to different scenarios where things are really, pretty bad. And they've got to be able to prepare themselves. So how do you disassociate with that? How do you not take this personally? How do you not take this home? How do you minimize the trauma that you're putting on yourself, but also on the trauma for all the individuals that are part of that incident? So this is why it was designed. As part of it, they have several tools within it, which would be the pre-incident education, the individualized crisis intervention, group debriefings. So these are tools that they included as part of the CISM model. So it was there, it was designed to mitigate those stress effects, right? Restore to normal functioning as quickly as possible. And then again, speed recovery from the stress that is associated, any kind of trauma associated with behavioral mental health incidents. So pre-incident education, this is kind of what we had talked about during the first two of this series. Within those lectures, we talked about, well, what are some of the triggers? What are some of the things that are coming up? And how can you prepare yourself for an incident that may occur? So you know it could be traumatic, not only for the individual themselves, but also for you and others involved who are there. So this is part of that training to get yourself prepared for how to deal with it. And that again, if you get into that situation, how do you get yourself to talk calmly, use that voice, put yourself in a position where you're not going to get hurt, but you're also not going to escalate the incidents. And that's where this education piece comes into play. So as part of that, we're helping you kind of develop this individualized crisis intervention. It's going to be different for everyone that you love and support. So some people, they may be able to help you identify what those triggers are. Other folks may have issues with communication. They may not be as vocal verbal in telling you what it is, but what are alternative strategies for getting that information? How do we individualize this? And one of the ways to really individualize the crisis intervention is to involve the participant themselves, involve the kid, involve the adult who has had these traumatic events, and help them identify some of the feelings, some of the issues that go along with crisis. Another tool they use is a group debriefing. And we want to kind of modify this and say the same thing, that if you have an intervention team that has helped you develop this individualized crisis intervention, the team as a whole can actually meet and debrief. Talk about what happened in the incident, what went right, what didn't go right, what were some of the barriers, and how can you change things as they come up, but also get that opportunity to kind of put a release out there in terms of what happened, because it can be traumatic for all folks, and that's this diffusing state. Within the diffusing, it is giving people the opportunity to kind of say, well, this is how it affected me. This is what I need to protect myself. This is that time again where if you need to walk away, perhaps you do. Take a break, do the box breathing, right? Hug your dog, hug your cat. Well, maybe not hug the cat. Sometimes that doesn't work quite as well. But what are the strategies that are there to help diffuse the situation, but also help diffuse or de-escalate any of the incidents that go with it? Now, with this, once you've met as a group, you start to debrief on it, you come up with these strategies to help diffuse. One of the things you're going to then talk about is, well, what's the follow-up care that is needed? Right? If someone has been institutionalized as part of this process, one of the things is going to be, well, how do we get them out? How do we get them back to normal functioning? And part of that's going to take some planning, because perhaps they were in an incident. The first responders may have been called where the police or the ambulance actually did the transportation. They took them to an institution where they took them to a regional care center. And the question is going to be, well, how do you get them out of that regional care center, right? What's our timeline? What are we going to do? For the most part, you're not going to call an ambulance. You're not going to call the police to get them back into society. So who's going to do that? What's the best way to do it? And can we do it in a way that's not going to set off any of the triggers that we've already identified? Or again, get back into that escalation cycle. So we want to talk about the follow-up care. One of the other things that really comes up in the follow-up care is mental health. How do you protect your mental health? How do you protect the mental health of the individuals that you're supporting? So at times, they get a lot of stress on, well, we've got a person who's gone through this and we want to talk about trauma and trauma-informed care, but can we actually take that unit of analysis to the bigger team, the team as a whole, or at least to the parents? Because a lot of times when we're working with kids or individuals who are supported by their parents or loved ones or guardians, whoever it may be, they don't always follow up and get the care they need when they're diffusing the situation, when they're debriefing on that situation, and then it can reoccur and it can cause trauma for them. So what are these different pieces that need to be in play for all team members? Right? Do we have some formal tools to analyze the incident? We can talk about it, we can debrief, we can have that vocal verbal response, but what are some of the tools that are out there to help us analyze what happened and help the individual realize when those triggers are occurring? And as they start to escalate, what are some of the strategies that are going to help them de-escalate to help them mitigate the situation so it doesn't get to that point again? So these are all the different pieces within the critical incident stress management, the CISM. So with that, we're going to ask a question. And again, this is, which of the following is a key component of the CISM? There are multiple answers here that you may say, hey, wait a minute, that actually makes sense. But which are the components within the CISM model? It is immediate medical intervention to treat physical injuries following the critical incident, providing legal advice to first responders after a traumatic event, pre-incident education where individuals and teams are prepared for potential critical incidents, are providing information on stress reactions and coping strategies, finding financial compensation to individuals affected by the incidents, or recommending psychological counseling for everyone involved in the crisis, regardless of their mental state. Turn it over to Celeste.
Okay, if y'all will pop your responses to that question in the chat, that would be awesome. There are a lot of words to read through there, so
There are.
So what do y'all think? Immediate medical intervention, legal advice, pre-incident education to prepare the team, assigning financial compensation, or recommending psychological counseling. Well, we have answers popping in here. We have 3 people indicating C, pre-incident education, 4 with C, pre-incident education. All right. Well, that is correct, right, Mark?
He is the right answer there. That is part of CISM, is that pre-incident education. And like I said, you know what? There were a lot of correct answers here. That is, you should be providing medical intervention to treat physical injuries following those critical incidents, but that isn't necessarily part of the CISM model. That CISM model is that pre-incident education. So perfect. You guys got those critical thinking skills firing. This is a good thing on a Tuesday. Way to go. So then we get into kind of what is post-crisis, right? And during this stage, right, this is considered the recovery stage. And this occurs when someone receives treatment and support and begins the healing process. So this post-crisis recovery resolution stage is the final stage, right? We've gone from the triggers, we've gone into the incident, and now we're talking about after the incident is over, or at least in that state of de-escalation. The reason I say it that way is they may be in a regional medical center receiving care, but as a team, it would be great if you all could get together, talk about what you learned, some of those issues that are there, and again, start that planning process for how are we going to get into the recovery stage? How are we going to get into the healing stage for the individual, but also for everybody else involved? So this stage, much like the others, will vary widely depending upon the crisis and the person involved. There is no linear state to this. There are times where things will seem a lot better and it may get a little bit worse. So be prepared for that roller coaster as things get better. Know that, you know what, it's not going to be a linear thing. It can happen. There is no timeline on this either. That is, many people say, well, you know what, it's over. It's time to move on. Let's get going. But you need to give people their own time to debrief, right? And talk about what those things are going on. So this should be a time of rest. It should be a time to build upon the strengths that you've found works that help mitigate it, right? And connect with resources that are there. So you may find, well, you know what, we need a counselor. We need someone to come in to talk to this individual during that pre-crisis stage when they start to identify the triggers. And we're going to try to give you some of the resources that are here as well. But there may be others out there in the community that you need to contact and make sure that they're involved in this post-crisis process. So can't overstress this. Allow time for the person to recover. People who have gone through traumatic events like this can find it to be confusing, especially if you have an individual who has a limited capacity for communication. They may not completely understand all the emotions that were experienced. So give them time to recover. Allow for them to be confusing. Right? Acknowledge that it may be difficult to discuss what happened, especially in traumatic events. It's often difficult to talk about it in a way or in a time frame that doesn't then trigger the next incident. So you want to make sure that they have that timeline that they need and they have the space that they need to do it. There may have been similar traumatic experiences in their past. This may re-trigger it. And at any point in time, if the person starts to show signs of discomfort or emotional distress, and again, this is sometimes harder to do for individuals who have communication deficits or may have different modes of communication, but you need to recognize those signs and pause the discussion so that it doesn't lead to another traumatic experience. It doesn't lead to another escalation. as appropriate. Make sure you have referrals in place, right? Do they need to talk to a therapist? Do they need to talk to a psychologist? Celeste brought up many of the warm lines, right? And some of those peer supports. Do they have peers that they can talk to? And we want to talk to peers that aren't triggers as well. Because sometimes their peers may actually come across as very judgmental, and that can then lead to another escalation cycle. We want to avoid that. Are there mentors? Whether those mentors be within family or be professionals. Can they identify who is there that helps them calm down or helps them recognize situations that lead to further escalation? So give them time, allow for confusion, allow for any kind of issues that are there. Yeah. So post-crisis intervention assessment. If you can, in the way that the person is going to understand, is ask that individual, what were your perceptions of the event? Give them the chance to tell you their perception. What happened? What made them upset? And maybe upset's not the right word to use. Is what happened on this day? Because sometimes when you say upset, well, then they take that as judgmental. So maybe a different way is, well, how are you feeling now? Versus how did you feel then or on this day? Can you help them identify any kind of coping mechanisms? What are the things that help them feel better? Right? This may be something simple. It could be something complex, but we've had some folks who that plushie is what they need as a coping mechanism. Right? They have the support plushie. Or there may be the mentor, they may be a family member they need to talk to. There may be the warm line, they need to just talk to someone about it. What are the support systems that are there? Who's available to help you? And as part of that, one of the questions is going to be, well, what if that person's not available? And if that person's not available, is that a trigger? Is that going to lead to an incident? So not only who's available, but is there a backup? And for the previous incidents, because we're now in that post-crisis state or stage, we want to know, well, who was or is most helpful? Who helps the de-escalation process? Can they identify the person by name? Was it abuela? Was it a best friend? Was it someone that you're working with, or was it you? And then again, we will start to identify, well, what are the strengths? What helped them de-escalate? What helped them calm down? What are the strengths that you can use to build different ways to communicate, that you can build different skill sets for how to de-escalate when it happens? Right? So did they try the box breathing? Did they find meditation works? What were those strengths that are there that you can build upon so that, again, when the triggers start to show up, how do you mitigate the situation so you don't get into the escalation cycle? So part of the assessment. As I said before, I'm really a big advocate for expanding the unit of analysis to include the family, at the very least, if not the whole team. So having children or siblings you care for with complex needs can be overwhelming. Right? We know the incident of divorce for individuals who have kids or who have even adults. I guess kids are adults. Kids can be adults. But if they are on the spectrum, if they are having complex needs that may include mental health needs, it can be very, very difficult for the parents, for the family unit. As time, the incident rate for divorce is actually greater than the general population, and it's a time where you may actually have to say to the parents, "It's okay. Be gentle on yourself. It's okay to ask for help." A lot of times parents don't ask for help for them. They ask for help for their kids, for the people they support, but it's okay for them to say, I need help as well. Is there a way to connect them with others who are on similar journeys? Not a big advocate for Facebook, but you know what? Facebook has its positives. One of the positives is, can they find others who have been on a similar journey, who can relate to some of the situations they've been in, and can actually act as that peer, as someone who can help them de-escalate when they're dealing with the trauma of the incident that just occurred. But the bigger message here is, when you're talking to family members, when you're talking to team members, tell them it's okay to ask for help. They don't have to do this alone. They can accept support, and that is the way it's going to help everybody heal quicker. So, offer that recovery for everyone involved in the team. So one of the things that's coming up is this debriefing process and tools. I actually have it brought up. If you want me to share this, I can share this. I'm going to try to do that. Share a new window. Can you see that okay?
Yes.
Okay. So the debriefing process after a behavioral mental health crisis, again, have that initial meeting. The initial meeting after the crisis is, the objective is to meet with the treatment team as a whole, discuss the incident, help the individuals feel safe, right? These are the big keys there. They need to feel like they're in a safe place, that they can have that lowered anxiety, the lower stress levels, right? And as part of these actions, ensure a calm, supportive environment. There's no judgment here. We're here to support you. Right? You tell us. And a lot of times people will say, you know what, this is my perception. And you have to realize that the perception of the individual who went through the crisis may not be the same as the people on the other end. They may have different perceptions on there. Can you carve out separate time to meet with staff who are impacted by the event? Talk to the different team members that are there. Have that incident review, that is understanding the sequence of events, identifying effective and ineffective strategies. Right? What was happening before the incident occurred? And again, get this from both perceptions, the perceptions of the team members who were there, but also from the individual themselves, and help them identify what was happening from their perception. What happened as the incident escalated? How did it get to that point where it couldn't come back? What happened during the incident? And again, what worked, what didn't work, what were some of those barriers? When you get to that planning stage, you're assisting and accepting the realistic goals to return to pre-crisis levels of functioning, if that's possible. How do we get back to where we were? And by doing that, we need those actions to establish the outcome measures, strengths-focused, problem-solving approach, determine the impact of services and intervention on the individual's mental and physical health. There may be a time period where they need more supports immediately when they're getting out of that incident, or if they're getting out of the regional care center. They may need some extra therapy during that time just to help process things, and can that be provided? Feedback from each individual, right? We're using person-centered planning here, and also from the support team members, because everybody offers different insights, and we want to get this so we can talk about the events, the current status, where we're at now, and again, the perception of the event from both perspectives. So what happened? What were the triggers? How are you feeling now? And again, that some of those keywords should be, are they feeling safe? Are they feeling like they can actually talk about it? What are some of the coping mechanisms that they have? Or what are some of the strengths that they have that we can help build into coping mechanisms? And that is, what helps them feel better? So what's the support system? What's available? Who was it? Who was most helpful this time around? And what are the strengths that help you get through the incident or are helping you in your recovery process? What are some of the follow-up actions that need to happen, right? Ensure ongoing support and adjustments of plans as needed. So if you need an extra person to come in on weekends or somebody to come in and help out, especially during that interim where they're getting transitioned out, make sure that happens. Make sure the folks who need any kind of de-escalation or any kind of debriefing get that opportunity to debrief. So schedule the follow-up meetings, adjust treatment plan as necessary. So this debriefing forum is going to be available as part of the resources that are there. You can use it as part of the team so you can go through it. And it basically goes through those questions that were there before. It's just a way to say, how do we get this more formalized so that we can get the information that we wanted to ask? So what worked, what didn't work, the planning stages are there. How are you feeling now? So
I posted a direct link in the chat. Sorry to interrupt, but if anybody needs to see a direct link, that should work. And then you'll be able to see it larger and be able to save it. Thank you, Mark.
Right. Yep. And then this is what we're trying to do with this webinar is to give you guys the resources to make it work for the individuals you're supporting. So try them out. You need to modify them a little bit. You can modify them as needed. Okay, back to PowerPoint. All right. That work okay? We're back on PowerPoint?
Yep.
Right. So within the debriefing, after a behavioral or mental health crisis, we're meeting with the individual's treatment team. We're talking as a whole. We're concurrently helping the individual to feel safe. We're reflecting on the biopsychosocial state of the person, right? Within all those realms, what happened, right? What happened as the escalation occurred, what happened during the incident itself. And again, this is getting back to the perception from the person themselves because they may have perceived it differently. Right? You may have perceived it as, oh, you know what, you kind of flew off the handle and you started into this rage. But from their incident, they could have said, you know what, I felt a lot of stimuli coming in, I became overwhelmed, and this was my reaction to that. So give them the opportunity to discuss it, give them the opportunity to share. On our planning outcome identification, if the crisis resulted in an external placement, such as a hospital, regional health center, begin the discharge planning as soon as possible. But again, remember, there are other people involved within that team that may need a little more time to kind of debrief themselves, to go through what has happened. But if you can take the opportunity while the person is still in that external placement to say, how are we going to move forward from here? How do we get back to our normal? Determine the impact of the services and intervention on their mental health and on their physical health. So yeah, there may be incidents that result in physical health issues. Do they need to see a doctor? How do we get to those doctors? How do we get them help? Again, if they have communication issues, this may require someone to go with them to say, well, this is what they're telling us. This is where it hurts. When it comes specifically to debriefing with individuals diagnosed with autism, the autism spectrum disorder, can you monitor for post-crisis sensory difficulties? Here's one of the issues that I've always had with sensory difficulties in that most sensory difficulties include both hyposensitivity and hypersensitivity, right? So there are some that it's hyposensitivity, that is, they're just not, they're kind of what people perceive them as being oblivious to the pain. They may feel it inside, but they don't show any kind of outward signs to this, right? But again, acknowledge that it can be confusing for them. They may not know how to process some of those things. There may be some sensory issues that they may even be more hypersensitive to sounds, to lights, to the way that you present yourself in your tone of voice. right? So monitor for that. Acknowledge that the individuals diagnosed with autism may present opposite emotions, right? They may laugh when people expect them to cry, but that's okay. And again, we're providing them a safe space, an opportunity to actually debrief on how their perception was, how it happened. If at all possible, ask clear, direct questions, avoiding slang, avoiding metaphors, any kind of social nuances, and avoiding any kind of coercive language or oh, what am I thinking? I just lost that word. Celeste, you know the word. It's me. What am I? I am sarcastic. That's the word I was thinking of. Avoid sarcasm.
Think I'm sarcastic.
I could not think of that word. Yes,
It's been a
but
day.
avoid sarcasm if at all possible. That can oftentimes lead to even more confusion. So explain any kind of positive coping skills, right? How they could be helpful. So you could talk about, again, any kind of meditation, any kind of box breathing, all these other different things that we had talked about. Find the ones that work for that individual. We're going to get into some other ones that may be helpful as well. But when it comes to crisis supports for the autism community, again, I think Celeste probably can put this in the chat. I'm going to try to pull it up again as well. Okay, let's see if I can pull this one up as well.
Or I put it in the chat for everyone.
Okay. Does it show, did it switch windows or not?
Yes.
Okay. So here's the crisis supports for the autism community. I'm a quick overview of it because you're going to have it as a resource that's on there. But it basically kind of helped us kind of go over some of those issues that you may be. So how to provide support for the callers, for the texters, and again, expressing those sensory difficulties, sight, sound, smell, touch. And again, some may be hypersensitive to it, some may be hyposensitive, that is less sensitive to it. They may present again with those emotion opposite of being in a crisis like laughter. I don't know if you've heard some of those stories, but there are certain people that they laugh at a funeral. But that's their coping mechanism. That's their way of dealing with it. And at times, I found myself in that same situation because I'm remembering that person and the humor that they provided to my life. And so I'm laughing along because that's what I'm remembering. And that's how I'm helping to cope through the situation. Literal thinking and understanding, again, understand that many individuals on the spectrum may have difficulty identifying or verbalizing emotions. This is a very abstract concept to many people. It is really hard to say, well, what did it feel like? Right? Or how did this make you feel when they're not really sure, well, what is a feeling? How does it do it? What is sadness? And so is there a way that you can actually talk about sadness? Is there a way that you can teach, well, this is what it's like to feel bad, or that something is wrong, or that they don't feel good inside, and actually teach towards that skill set? Literal thinking and understanding, again, avoid the sarcasm. Finally got that word. I'm going to use it again, sarcasm, sarcasm, sarcasm. Have they experienced countless misunderstandings and miscommunication? That is one of the big issues, right? For many times, and this is where we've run into it with doctors that will come in, they will talk to the family member, but they talk over the individual themselves, right? This is not best practice. This does not help the situation. We've got to help educate the doctors and say, talk to this person. It's their life. I'm just here to support them. I'm here to help them communicate to you what the issues are, but ask them. Their difficulties or an ability to make friends and sustain relationships. Right? So That is one of the hallmarks of social issues related to autism. They're there. Any kind of unusual patterns of speech, odd pitch, tone, pace, or they may have what's called robotic speech, but that may be the way that they actually learn to speak. And the question is, can we see that ability to actually vocalize as a strength, and how do we build upon that to get there, rather than see it as, well, this is an odd tone or this is very robotic speech. Let's pivot and talk about how can we use this as strength? How can we build upon it? So perhaps they need to text. So the nice thing about texting is it takes out the social context that's out there, and they can actually sit down, they can be in their own world, and they can text and be out and share that information. So can we do that? They may have echolalia in terms of the repeating the words, the sounds, the responses that are within there. So again, asking those direct questions, avoid those nuances, the metaphors. So that is there for you as a resource. Hopefully you find it as enlightening as we did. Really used it to kind of shape some of these slides that we have here. So back to the PowerPoint. Did that go back okay? So we're going right into a knowledge check, and Celeste is going to put this into the chat for you. So what are some key questions to ask a person who just had a crisis during the debriefing stage? So during that post-crisis stage.
Okay, if you will please put in some responses to what you think would be some important questions to ask to the person who is in crisis during the debriefing, or has been in crisis, rather. Just your thoughts. We're eager to hear what you think might be helpful. Oh, okay, good. Anne McHugh, what was going on with you? How are you feeling now? Alyssa Aaron said, how are you feeling now? I mean, I think those are great to like reestablish a connection with the person. Sometimes we find that people are feeling stressed or even embarrassed about an event that happened. They're sorry and they're apologetic, and they may be needing to hear from you that you're, wanting them to communicate with you, reestablish that communication. How are you feeling now is a great way to do that. How can I help? That is a wonderful thing to ask. I think a lot of times people will ask those questions about helping with yes, no responses, like, can I help you in some way? Right. But if you ask, how can I help? You're actually asking for people to give you some points and tips that might help you know how to help. What is it that you need? Right. I know that being a girl from the South, asking what you can do for a family after the loss of a loved one or similar situations. Like, how can I help? Can I start a meal train? Or do you need someone to sit with you and have a prayer? What is it that you need to feel supported? So those are some great examples. Thank you for sharing those.
Yes. Well, I think another one that I really want to throw out there is that, are you feeling safe? Are you okay to talk about it here? And let them know that, you know what, if they need to take a break, all they have to do is say so. So you give them the opportunity to say, this is a safe place. We're going to come at this with no judgment. We want to know your perception. But yeah, so a lot of those questions are out there. I believe we've got this quiz coming up again. That is following a crisis event for an individual that involves transportation to emergent facility. What should or could the team do immediately? So got to the point, they've gone through a crisis. The crisis then goes into that regional medical center. And it may not have been a family member or someone who got them there.
This one's a multiple choice question, but I think maybe the animated text needs to be clicked so they can see the option.
Okay. Oh, yeah, there we go. All right. So do root cause analysis to determine the potential cause of the crisis, convene to plan for an effective transition back home, contact the local authorities to notify them of the individual's release, or just pretend like nothing happened because that'll help them calm down. Well, thanks for that prompt. Multiple choice. Celeste, you have your therapy cat with you.
I know. This is the omnipresent white cat. And if I get on a computer, she will literally force the door open, which she just did. Sorry, folks. Hopefully you're not allergic over the web here. All right, so we're seeing some answers of A, do a root cause analysis to determine the potential cause of the crisis. All right, Mark. What do you think? Oh, we see it.
It's a great answer, but the one we were looking for was that B, that is convene immediately to plan for effective transition. That is, use the time during the post-crisis to say, well, how are we going to get back to normal?
How do we get the person home? Right.
Yeah. How do we do the next steps? And the next steps may be that root cause analysis to talk about what are those potential causes. But even that may have been done during that pre-crisis phase as well. Because what are some of the triggers? How do we get to some of that? So it's not necessarily a wrong answer, but the best answer here may be convene to immediately plan for effective transition back home. So I don't know, do we need discussion on that, or does that seem acceptable to others? Okay, they're accepting it. All right. So ensuring continuity of mental health services. So some of the things to think about, again, this is that post-crisis phase. So after the crisis is over, some things to consider. Do we need to access counseling, peer support groups to offer continuous support for crisis? So we want to help them get back into that normal state. Do they need some counseling? Are there peer support groups that are out there? Again, this is not just for the individual themselves, but for family members, other team members that may be there. At times, some of our research has been saying, you know what, there are faith-based support groups that are available, and oftentimes they have been really helpful for people who have gone through crises in providing that support group for them. So, ensuring mental health professionals are adequately prepared to address the unique needs of the individuals with IDD. And again, this may come back to where if you have a physician, if there was some physical harm, if they need to go to a hospital, they need to get patched up in any way, how can you help them communicate with others that are there? How do you educate them on the unique communication strategies or the needs of these individuals who may have issues with expressing exactly how they feel or what is going on? So can you conduct that needs assessment to identify the gaps in the mental or behavioral health services and recommended changes, right? Because if that is a barrier, if that gap is there, how do we close that gap? How do we get mental health services to individuals who may be in the IDD system? We realize that there are mental health issues related to having intellectual developmental disabilities. The top two, depression and anxiety. There are many individuals who have alternative communication strategies that just feel depressed, but they don't have a way to express that depression. How do we improve the quality and professionalism of both the mental health workforce through training, education, certification, continuing education? right? How do we talk to them about, well, what's going to work? How do we get to that pre-crisis stage to say, here's how we were going to recognize these things that are helping, or here are the things that lead to crises. How do we do this? How do we get out and educate others in terms of even first responders, so that when you come upon this scene, here's what we need you to do. There's been several incidents of individuals who have engaged in problematic behavior, they have a mental health crisis, and they may need the first responders to come in with their lights or sirens off. Right? So how do we get that education? How do we talk to them? How do we get that training out there? Well, one of the ways to do that is through webinars like this. How do we help people educate others? How do we increase staff training to access appropriate treatment and service? Again, what we found is there are oftentimes different systems. We've got a mental health system, we've got an IED system, and sometimes the two don't play well in the sandbox. So how do we get them to do that? How do we get mental health services for individuals who have IED? How do we develop outpatient supports and planning to provide critical post-crisis support? So what's needed there? And this may start with transportation, but it could go even further than that. What are the mental health needs? What are the, how do we find a therapist that's going to work with someone who has intellectual developmental disabilities? How do we teach them to identify some of these issues in terms of what emotions are? How do we get them to learn the different strategies that we've identified may help de-escalate? And then how do we create a structured environment with multiple levels of support for individuals following the crisis? And we need them to feel safe so that they can share the information. They are the person. They are the person-centered planning that we're going to do our planning around. But we need to have multiple levels of support. So as part of that, it is, well, how do we get this cross-professional collaboration and coordination? This has been an issue and probably will be an issue for the greater time that is there. That is, there are different people that this is my wheelhouse, this is where I work. I don't necessarily work well with others outside of my train of thought or my training, but it can happen. And what we want to do is figure out, well, how do we get professionals to collaborate and coordinate services across it? Because that's what's going to keep the individual from having further incidents and from being taken and put into those regional mental health facilities or the crisis facilities. So first one, prioritize incorporation of the collaboration, right? This has to be the priority. We need to talk about communication methods that work. And how do we collaborate between systems, organizations, and the families and caregivers? Oftentimes, after the incident is over, people don't talk to the family members about what happened. But how do we do that? And how do we get the right people to talk to them? How do we do this as a team approach? Right? How do we get therapists to be involved if therapists need to be involved? How do we ensure effective communication? Evaluate the strategies that facilitate that communication between service providers. So you may have a case manager. Is the case manager talking to the people who are providing habilitation services? How do we get the OT, PT, these other paraprofessionals involved? How do we get the behavior analyst as another paraprofessional involved within it? And how do we get them to communicate across the service provision? So coordinated treatment and care should be prioritized. We want to align the post-crisis treatment and care options across all the providers. Remember, this is about the individual, not about us as professionals. It's about how do we best serve this individual? How do we best serve this family? How do we work as a team to make their lives better, to help them heal, and how do we get back to what was normal? We want to foster positive outcomes. because collaboration between educational institutions, support agencies is going to actually do that. How do we get the trainings out there to help people learn what they need to do in a crisis situation? How do we teach individuals who have a mental health background? How do you communicate with individuals who have alternative communication strategies? How do you recognize those signs that may be more nonverbal than verbal? How do we define and administer clear strategies? Right? We define effectively administer the post-crisis treatment and strategies. We're going to put it down. The best way to do that is put it on the paper. Right? And that's why we're giving you those resources so that you can go back. You can say, here's our process. Here's what we're going to go through. And from this, we're going to say, what are next steps? Because that's going to help promote that effective cross-professional collaboration, should lead to coordination for better post-crisis outcomes. Because again, it's about the individual themselves. How do we get them in the best place that they can be? So, back to a knowledge check. So what are the strategies to promote effective ongoing support and treatment? Well, that is not a multiple guess. So this is open-ended. So what are some of the strategies that you have used? What are some of the things that worked for you to promote ongoing support, treatment, or even collaboration?
Okay, we're waiting to monitor here and see if you have any helpful strategies that you've used that you could pop into the chat, if you don't mind.
Help educate us.
It's bidirectional communication.
Yes.
Ooh, okay. Locate resources to address the needs of the individual, holding team meetings. And I think it's important to do both of those things in an ongoing way, right? You don't just have one meeting after a crisis event has occurred, but making sure you're constantly checking the system, I think, is so valuable. All right. So we got 2 responses there. Mark also talked a lot about coordination of services between team members. It can be hard to get people together in the same room. Maybe that you at least are able to like share notes back and forth now that we live in such a connected world. You know, even getting some kind of a report sent electronically about different professionals' perspectives would be great. Support groups for individuals and their families. Those are great, great suggestions, y'all. In some cases, I think if people can't find a group, we can try to create them and help support people finding other families and support groups to connect with. Could be, uh, I've seen a group called Parents Encouraging Parents around Florida. I don't know if anyone here has heard of that. There's so many other organizations that people can form those important connections. And I think because people often can be so isolated when they're working with someone who's dealing with a behavioral or mental health crisis in an ongoing way, sometimes that virtual check-in can be really important. So let's not forget that even if you can't meet at like the local cafe and sit down and talk to each other face to face, quite often a Zoom call like we're doing right now could be an effective way to help people just connect with another person. So thank you for that, Tracy. Friday reports and check-ins with the individual to assess the individual's perspective on supports and needs. Okay, so you're going right back to the whole idea of nothing about me without me, going back to talking to the person supported and making sure you find out how they're feeling, what they need. That's wonderful, Sheila. All right, we got some great input there.
Yeah,
Thank you.
thank you. Yeah, thanks. That's going to help us moving forward as well. I do really like that idea of using text and using alternative communication strategies. Sometimes it's easier just to put an emoticon on there than it is to try to spell it all out. And we both know folks who that is their preferred method, and we want to go with that. That is, what's their preference? How would they want to communicate? I've got a niece who will not answer a phone call, not whatsoever. But if you text her, you will get a response generally within minutes. Make sure we know what those are. The case study for Nacho, I kind of give a brief description of this one. But we've got Nacho is an 18-year-old Cuban American with a diagnosis of autism and schizoaffective disorder. Communicates using simple phrases, short sentences. He lives with his mother and two brothers in an apartment in an urban area and attends a high school pre-vocational training program. So in terms of medical history, primary diagnosis is autism spectrum disorder, secondary diagnosis of, again, schizoaffective disorder. Some of the symptoms related to that: occasionally experiences delusions of persecution, which can escalate quickly, leading to 911 calls and hospitalization. In terms of medications, it takes Invego to manage mental health symptoms, which I would mess up that word, so I will leave that up to Celeste. Paliperidone, I believe it is. In terms of medical history, he's fit. He's a healthy young man with no significant medical conditions. His family medical history, that is, Nacho's father had a history of substance abuse disorder and an unknown mental health disorder. His mother reports a history of abuse by his father. So the background, there's a medical history, psychosocial history. In education, he's attending a full-time high school vocational program, that pre-vocational training that he's getting. He has a religious preference. He attends church services weekly, and members of the congregation, especially the three male elders, are very supportive of him. He reports no friends, but often sits with another boy at school, and he considers his brothers his friends who can help care for him when the mother is at work. In terms of other support systems, again, we've got the two brothers, Diego and Miguel, his mother Maria, three church elders, Derek, Tom, and Carlos, and his school psychologist, Dr. Tessa Smith, and a psychiatrist, Dr. Kelly Warwick. So in terms of leisure and preferences, he enjoys building with Lego bricks, watching soccer, playing video games with his brothers, and playing soccer with his brothers in a nearby school soccer field. Socioeconomic status, the family does struggle financially. They receive SNAP and EBT benefits and regularly visit a food pantry at their church. The presenting problem that we're dealing with, or that hopefully you can deal with, is he was hospitalized for 3 days after an episode where he made verbal threats. He caused property damage and ran away from home. During this incident, it followed 2 days of refusing to take his medication. He experienced delusions about bad guys wanting to hurt him, leading him to punch holes in the walls and threaten to run into the road. His elder brother called the mobile response team, who tried to intervene, but during this, Nacho fell and injured his shoulder while attempting to escape. So our trauma-informed care plan, that was his support team, discussed his history of trauma, including the abuse by his father, the recent injury during the crisis. They emphasize avoiding outside intervention whenever possible, ensuring that his medication is taken on a regular basis. The team agreed to document any early signs of concern, such as talking about the bad guys or feeling threatened. If 2 or more concerning behaviors occurred within a day, the family would contact the support team to intervene, while trying to engage him by inviting him to watch a soccer game on television, going back to those preferences. The church elders agreed to visit to help de-escalate any developing crises by engaging him with his Lego creations or video games. And the support team also planned to undergo training and safety management techniques. His mother agreed to notify the psychiatrist and school psychologist about any changes in his behavior or triggers that may upset him at school. So there's our case study. What goes along with this is, could you tell us what are some interventions would you employ to help Nacho and his family prevent the recurrence of a crisis if he begins to express fear of bad guys? A, we just ask him to calm down and take a walk. Tell him he is imagining it and that he is safe. Immediately begin redirecting him with soccer on TV or Legos, or ask him if he wants to watch animal videos. So again, I believe this description is going to be included in there.
So we have lots of folks answering D, to immediately begin redirecting him with soccer on TV or Legos. And I think often we minimize the importance of early redirection when it can be a really effective strategy, instead of just focusing on, what's wrong with the person. But like, can we get them to talk about or do something else? It is not always going to be effective. There are some times when other intervention is going to be warranted. So we have all letter C's here in the chat. Very nice.
Sounds like, yeah, they picked up on it. That is, we know what his preferences are, and how do we use those preferences to help de-escalate? I still have that question, and I will throw it out there to them, is to say, in the history of people telling people to calm down, has it ever worked to help them calm down? I haven't really seen that. Hey, you just need to calm down.
Generally, no, in my experience.
That has been my experience as well, right?
Calm down is almost like adding actual fuel to most people's flames.
Yes, it may be identified as a trigger for some. Okay? You
Mhm.
tell me to calm down, that's going to be my trigger to escalate. But yes, you all had the right answer. That is C, immediately begin redirecting them with soccer on TV or Legos. So these are just some of those strategies. And again, when you're doing the post-crisis, the question is, well, did it work? And if it didn't work, what are some ways that you could change it so that it would work? Or like Celeste said, how do you recognize some of those signs that say, you know what, we need to go to the next step. We need to have a different way of getting him to de-escalate. So, as part of the process here that we're in this post-crisis stage, what we're hoping you do is amend the crisis plan that you have. And we're talking about what works, what doesn't work, how are you going to use that knowledge to amend it. This again is available to you as a resource, and it is the link center that is kind of going along the lines of what we had talked about before. So helping them identify what their triggers are, right? What they can do when they start to get upset. And we used to call it, or at least I used to call it, a green light, yellow light, red light strategies. That is, when things are going well, what are the things that made it go well? When you start to get to the yellow, how do you identify that things aren't going quite as well? Right? And then we get into red, that's where we get into those crisis states. We start to see the escalation. What are some things you can do to help de-escalate? So what can they do to help them calm down? Let them know that they're safe. Would it be encouraging them to breathe slowly? So the big ideas here is all within that document. What is a crisis? When does a crisis happen? What's the crisis plan? In other words, to know. So this is, again, just a way of documenting it so that you can provide this to other people that may find themselves coming into the situation, so that they can be prepared and they know how to react in a way that's going to help de-escalate. So it is a working document. Hopefully it works for you. But again, if you need to tweak it a little bit, you can tweak it. Another one that's out there is the NRC PAD, which is the Psychiatric Advanced Directives. I believe Celeste, you talked a little bit about this before in the other modules. And this is kind of like, well, when things go wrong, what are we going to do? And it may be as simple as, well, what about transportation? So if someone is in the escalation phase of the crisis, how are we going to get them to the point where they can get help? So would that be calling the first responders? Would that be calling an ambulance? Is there a family member that can help take them and help them de-escalate as they're there? The state of Florida has been implementing the crisis response teams. They are spread throughout the state. There are some folks there that have that. Or would it be even as simple as calling 988 and getting someone there to talk to, or perhaps a warm line or peer supports that they could do? So again, this is just another way to document it out so that you know exactly when the situation is occurring, what are the triggers, how do you do this, how do you change it, how do you de-escalate? So in terms of amending the individual's personal crisis plan, and again, the emphasis is going to be with them involved. We want them to feel safe. We want them to be able to provide the information because it's their life. When we're amending it, we're hoping that you have learned from the experience and that you work with them to enhance their plans, ask him, her, them to share their experiences. What was it like for you in the crisis? So some ways of reframing that would be, well, how did you feel before you became upset? Assuming that upset is not a trigger word. When you're feeling bad, did anything happen to make you feel worse? You're feeling bad, did anyone or anything help you feel better? So can you think of anything that would help you feel better when you're upset? These are all getting at the same ideas. They're just different ways of phrasing it. And again, tailor it to the individual you're working with, to their communication strategies, in making sure that there aren't any kind of triggers within there, right? Well, you may want to ask about medication. For some folks, you may not want to. So what do they do to feel better? I really like this example. I'm hoping it's in the resources at the end of it. This was actually developed by a young lady who has autism, and it basically is kind of that cookie cutter of a gingerbread person. And what she said was, you know what, you can provide this to someone who may have limited communication and have them indicate what they started to feel either pre-crisis or during the crisis, right? And this can be done after the crisis is over to say, rethink what happened in there, right? Because when they're calm, they're able to communicate without the agitation, help them identify those emotions that are there. So they may be able to identify, well, you know what? When I started to do it, I started to feel very flush, right? My face got red, or I could feel the heat there, and they can actually identify that. They may get sweaty palms, or before I knew it, I looked down and my fists were clenched. Where they had that fight or flight, that is, they wanted to run, they wanted to get out of there. Right? Heart rate started going up. So these are ways to help the person identify some of the emotions, some of the triggers, some of the signs that lead to crisis intervention, or to the crisis itself, or during that escalation. And if you get to the point where they can actually do it, perhaps if they say, hey, you know what, I feel my heartbeat, it was really beating really fast, well, perhaps you can use that as a way to help de-escalate. How do we get your heart rate down? What kind of strategies would help you do that? That should be available out there. We got another ASR. So we want to help the individual learn from the crisis experience and improve their plan. What is the key strategy you should use? Should you assume you know what caused their crisis and adjust a plan without consulting them? Should you focus solely on medication adjustments without considering emotional experience, avoid discussing the crisis to prevent upsetting them any further, or ask the individual to share their experiences of being in a crisis by asking the questions such as, how did you feel before you came upset?
Answers are rolling in quickly this time. We have Anne McHugh as the buzzer beater. If this was a trivia night, then I believe the highest number of points might go to our very rapid and correct responder. So thank you for that, Anne. Awesome. So we're seeing D, 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 D. Mhm.
Is that correct answer? Yep. Ask the individual to share their experience. Again, letting them know they're in a safe place. There is no judgment. But how did you feel before you became upset? Using that to help shape the future so that we don't get back in that escalation pattern. At some point during this post-crisis stage, you may want to determine if changes in medical care are warranted, right? Are there any kind of labs, are there any kind of tests that need follow through, especially if they're in a regional center and they're coming out of that regional center, there may be some additional tests that need to be done. If the medication has been changed, you want to make sure it's safe. Is there any kind of need or change in schedule for psychiatric help or therapy appointments? Right? Again, this may just be in the interim. It may be that they can go back to their monthly visits, but as they're transitioning out, getting back into the normal phase, they may need a couple appointments in a row just to get them back on the road to recovery. So, ask for recommendations, referrals, or assessments. It never hurts to ask the folks who are in those situations that are actually in the centers themselves. Maybe they have recommendations. Maybe they can give you a referral for a therapist or a mental health coach or any kind of psychiatrist or psychiatric help that may be needed. Are there behavior analysts, therapists, physicians, social workers, occupational therapists, physical therapists, other professionals or paraprofessionals that are out there that can help with the return to normal, return to health? So that's how we're going to get that kind of information. We're going to put that in that advanced directive as well. And then as we're revising, some of the things to think about, some of the things to take note of would be, again, what are the warning signs or precursors? Are they the same as they were before? Did they change in some way or another? What are coping strategies that worked? Or were the coping strategies that you had written down that you thought were worked that did not work? It may be that they were supposed to make a phone call to a peer, but the peer was not available. And so it'd be important to note that. What are the distractions? What are the people, the places that offer comfort in a time of distress? So it may be watching soccer. It may be that cat that kind of jumps up on your screen every time you're online. It may be that dog or just taking the dogs for a walk. Are there certain people? Are there certain places that you can go? For me, it's great to just get out and hike in a desert. I don't know why it works, but it does. Right? There's not a lot of people out there. It's just a good thing for me. It helps me calm down. Although, again, not recommended at this point in time because right now we're in a heat advisory. So, please don't do it if you're going to put yourself at risk. Uh-oh. Here we go. Who helps you make you feel better when you socialize with them, right? Who's your friends? Do you have a number of them? Is there a list of personal supports, any names, contact information? Is there a way, and it may even come back to the modality, right? It may be a phone number or it may be, I need to text this person. They're not going to answer the phone. So if you're going to contact them, how do you contact them? What's the way that's going to help you get through? Who is that person that knows what they're going through? Is it a peer? Right? Is there some kind of peer support system that's there? Is it a parent? Is it a sibling? So who are those folks? How do you get in contact with them? Are there professional supports? Is there a number for a mobile response team in that area? Is there a preferred mental health clinic that they may need to go to, or a crisis center that they would prefer to go to? So we're going to, again, write those all down. And this is as part of that debriefing, we're going to say what worked, what didn't work, and how are we going to change things so that we can make it better. So one more knowledge check out there. When reviewing the current crisis plan for an individual, which of the following actions should you change or should you consider to determine if changes in care are warranted? I thought that was going to be it. It says which of the following actions, but we are going to put this as an open-ended question. So what are some of the actions that you could consider if changes in care are warranted?
We would be happy to hear your thoughts. If you've got some comments or considerations, you could add to the chat. What would you consider to determine if changes in care are warranted in a crisis plan? Oh, Anne McHugh, good one. Update the warning signs and precursors and add coping strategies. Definitely. Each time an incident occurs, it is very stressful, but it's also informative and it can be educational for us as support team members because we can observe what was different this time, if anything, what made things better, what made things worse. I know that Mark discussed on a previous slide how important it is to talk about what worked and what didn't work after a crisis. And this is where what Anne is offering is so important. What worked, what didn't work? What are precursors that are earlier that we could respond to? Tracy Cox said, add additional therapies if needed. And that is on that top 10 list of comments that we discussed as we developed this training. It may be that upon discharge or before discharge is initiated, we're going to immediately try to get a person in for services in the community. And McHugh also offered that support teams can be more attuned to the early signs, which definitely speaks to that need for us to be observing carefully for any indicators as early as possible. It's a little easier to intervene, much easier, I would say, when you're at an earlier stage of crisis development because you may not have had to involve any authorities. Maybe the neighbors aren't yet hearing or being concerned. So it's so important. We may not prevent every incident from escalating. Sometimes there are cases where a person, maybe their medication isn't working for them, or they've become unstable on that medication because in the case of like bipolar disorder, some people, when they're in a manic phase, their metabolism is higher. So they would then potentially need a doctor to evaluate whether an adjustment to their meds needs to be made. If we start to see those precursors that you all are talking about here in the chat and from what Mark said, we're able to hopefully get those phone calls that we're seeing signs, early signs, and ask for the support and help if changes are needed. Very good. Did you want to get any more, Mark? I think you have 30 minutes left to the end, and you're pretty close to the end. So another thing to think about is consulting with other professionals in the person's life, like behavior analysts, counselors, social workers, for recommendations. And I find that when you do convene a team this way, either preferably before discharge, but certainly as the person returns to the community, it's really valuable to get the input of other professionals who may see things from a different angle and be able to contribute.
So I think what we could do too is, like I said, we're kind of near the end of the slides, but what I'd really like to do is let's go through the rest of them.
Yes.
Maybe then we can get Kristen to turn off the camera, and if people had information to share and they would feel more comfortable without the camera on, so that you can talk about individuals you're working with, because again, we're trying to do this as a workshop to kind of give you strategies. Does that work, Kristen?
Yeah, so we're on pause. Is that what we're doing?
Well, we're going to go through the summary if we can do that, and then we'll take that pause. Will that work?
Yep, that sounds good. And what I'll do, since the group is so small, and this is kind of our core team that's part of this since the get-go, I'll unmute everybody. So you guys will be able to actually talk live after we just close out our slides here, so that way you can ask questions or engage more directly.
Perfect. I appreciate that. So in summary, we kind of got over the critical incident stress management, some of the tools that are there, the different pieces that they do in terms of debriefing, talking about what happened, getting the perspective of different team members that are there. This need to ensure ongoing mental health care, not just for the individual themselves, but for the greater team. Whether that's the parents, whether that's family members, whether it's individuals that were involved in the crisis itself, they may need to have that same safe space where they can actually talk about what happened. We had gone over the importance of collaboration and coordination. This is easier said than done sometimes. There are some folks that really do want to collaborate. I found it works very well. But I know some colleagues who have said that it didn't work quite as well for them. And then the question is, well, how do we change their behavior so that we get that collaborative effect? Because the collaboration and the coordination of services across the different venues are going to help this individual. So
It's a great point that you make, that some people certainly will have that reaction of, wanting you to stay in your lane. And I think it's important to do that, acknowledge that we all bring something to the table. But I've definitely had those experiences where I've had physicians say, ask me a question, bring me some data, ask me my opinion instead of telling me, I think you need to increase the medication or decrease the medication, because that's not in our scope. We can present data as behavior analysts, for instance, and say, hey, we noticed this increase in concerning behaviors indicating a crisis, impending crisis, and then be ready to listen for details.
can't stress that enough. Collaboration, coordination across the different systems. Talk about that debriefing process, some of the tools involved in the crisis plan revisions, that is getting that information. How are we going to identify triggers? Maybe they're new triggers.
Mm-hmm.
Maybe going through that incident in and of itself created trauma that is associated with different triggers. And so now we need to know what those new triggers are. Or perhaps the person has become a little more self-aware of some of the situations that set them off, and that they can offer better insight into what does occur and what happens. And you know what, I noticed that my heart rate was going up, and so therefore I can say, well, this is one of those triggers or one of those early warning signs that helps me know that I need to go into these other strategies so I can help de-escalate, so I don't get to that point. So within the debriefing, some of the things that it should do is it should help mitigate the impact of the traumatic event. Right? If debriefing is not reducing that impact of the traumatic event, we need to reassess on how we did our debriefing. We need to do a different approach to it. And again, we got to make sure that people know they are in a safe, a gentle, judgment-free environment. That's the only way you're going to get that information from them that's going to help you revise your plan so that it is more effective and helps to mitigate those issues in the future. So can we, through this process, the debriefing process, identify adaptive strategies that can proactively prevent and protect? That's really what we're trying to get to. How do we identify situations? How do we identify strategies that help the person de-escalate so that they no longer have incidents, or if they have incidents, at least it's mitigated to a point where it doesn't lead to a full-blown crisis? And what are we going to do with that? So that's where the debriefing should come in. When you are debriefing, you should see this as an opportunity to learn, right, from the individual, from the team, and all the others that are there about information to revise your crisis planning approaches. We're trying to gather more information to make our approach more effective, more efficient. Again, be patient. There is no correct timetable for healing. Some individuals may have unusual reactions to it. They may laugh when you expected them to cry. They may cry when you expected them to laugh. So understand that people need time and they have their own timetable on how they're going to process things when it comes to trauma, when it comes to previous incidents. And the utmost one is U.S. professionals, U.S. support folks need to make sure you include self-care strategies for yourself. Identify when things are triggers for you and identify strategies that are going to help you calm down and process all the things that you've got to deal with as part of your work life, as part of your home life, and practice those self-care strategies. Resources are here. This will be available. I think Kristen said it's going to come out on Friday. So this Friday, you should be able to see this. Those are the resources that we used in developing this. There are the references as well for the articles that are there, and that just so we know that we're doing evidence-based support strategies we're doing here. With that, here is your model for post-test, and this is the point where hopefully Kristen can come in. She can